Alcohol is a teratogen, a substance that causes permanent birth defects. Alcohol is a colorless, volatile flammable liquid which is produced by the natural fermentation of sugars and is the intoxicating constituent of wine, beer, spirits and other drinks, and is also used as an industrial solvent and as fuel. Women and alcohol. Australian women on average reported drinking 3.5 standard drinks a day. With 50% of pregnancies being unplanned, the recent statistic is concerning. Recognition of pregnancy tends to average at 4 weeks. Figure 2, shown here, shows drinking before and after knowing about their pregnancy. Women ages 14 to 49, studies taken in 2016 and 2013. There isn't much difference between the 2013 and 2016 statistics, and the concerning factor is that only 50% of drinking habits decreased after finding out women were pregnant. Alcohol and sexual behaviour. Drinking increases the chance of risky sexual behaviours due to alcohol's intoxicating and inebriating effects. These result in behaviours like multiple and casual partners, sexually deviant behaviour, inconsistent use of protection, and poor social judgment. These behaviours result in increased rate of STIs, unintended pregnancies, sexual assault, and younger age at first pregnancy. Alcohol in pregnancy. Alcohol enters the mother's bloodstream and passes through the placenta to be carried through the umbilical cord to the baby. 56% of women in a recent study had consumed alcohol during their pregnancy. 26% continued to drink once they knew they were pregnant. 78% of pregnant women who consumed alcohol while pregnant drank monthly or less, and 17% drank 2 to 4 times a month. 96% usually consumed 1 to 2 standard drinks, but 1.4 had consumed 6 or more standard drinks in at least one occasion during their pregnancy. Figure 4 shows drinking in pregnancies by selected groups in Australia, 2016. The interesting result of this statistic shows that the higher socioeconomic areas show the highest percentage of drinking while pregnant, which goes against the stigmatization that lower socioeconomic and Indigenous populations show the most of this behaviour. Predisposing factors. Unplanned pregnancy. 50 to 70% of pregnancies are unplanned. Mothers may be unaware of their pregnancies in the early weeks. Unplanned pregnancies often lead to women unintentionally drinking while pregnant. Women that consume a high amount of alcohol or who take birth control may not recognize the signs of pregnancy. Consequently, unintended fetal alcohol exposure is common. Alcohol dependence. 2.3% of Australian women are alcohol dependent and are often unable to stop drinking even after finding out they are pregnant. This dependence is defined as regularly drinking in excess of the NHMRC guidelines for safe alcohol consumption. Impacts and effects of alcohol in pregnancy. These include lower birth weights, miscarriage, stillbirth, premature birth, birth defects, and a range of conditions known as fetal alcohol spectrum disorder. Fetal alcohol syndrome disorder refers to lifelong physical and brain disorders that can affect unborn and newborn babies due to alcohol exposure during pregnancy. These include growth deficiencies, mental impairments, facial dysmorphology, visual impairment, and behavioural problems. These outcomes create financial, physical, and psychosocial implications that have significant effect on the child's quality of life. Social determinants underlying alcohol use in pregnancy. The social determinants underlying alcohol use in pregnancy include family functioning and violence, poverty, unemployment and homelessness, stress and lack of knowledge of strategies for coping with stress, the role of alcohol in society, social pressures to drink alcohol and poor role models for some women, low self-esteem and social isolation faced by some women, poor knowledge about the impact of alcohol, and mental health and illicit drug use. Demographic and socioeconomic factors. Alcohol becomes an increasingly prominent part of everyday life when economies prosper. Recent epidemiological studies have shown that social inequities and alcohol use and related harm are characterized by complex relationships. They do not follow a consistent pattern and vary from group to group. Studies have shown that the use of alcohol increases with increasing education and increasing income. Women of any socioeconomic standing or educational level can bear a child with fetal alcohol syndrome disorder. Women from lower socioeconomic standings are more likely to have children with more severe forms of fetal alcohol syndrome disorder. However, women who are highly educated and have a higher socioeconomic status and drink socially are more likely to have a child with fetal alcohol effects. Although their child might be less severely affected, this is often worse than having full-blown fetal alcohol syndrome because individuals with fetal alcohol effects are often viewed as lazy or stupid due to their invisible disability and often go undiagnosed. Drinking during pregnancies resulting in fetal alcohol syndrome disorder is still believed by some to associate and occur only in Aboriginal and Indigenous populations. Interestingly, recent studies have shown that white women are more likely to consume alcohol during pregnancy. The stigmatization of alcohol use in pregnancy being an issue that only exists within Indigenous populations is false and harmful. Poverty, low social support, abuse, socioeconomic status can lead to the behaviour of drinking during pregnancy, and poor minority groups do experience less social support and high issues with the criminal justice system. Familial and demographic factors play a crucial role in women's likelihood of drinking during pregnancy. For example, engaging in binge drinking behaviour coming from a family origin of heavy drinkers or having a partner who is a heavy or frequent drinker can increase a woman's risk of drinking during pregnancy. Partners' drinking habits are also important due to the connection between alcohol use and partner violence. Partners play an important role in the encouragement of alcohol-free pregnancies. Being a victim of partner abuse, either physical or verbal, may influence a woman to drink as a means of coping and escape from the abuse. About 50% of pregnant women continued to drink during pregnancy if their partners were heavy episodic or frequent drinkers. The normalization of these types of behavior through family or partner influence is very dangerous. We as a society often neglect to acknowledge or take into consideration the social and psychological implications of a woman's drinking behaviors. The problem of maternal drinking during pregnancy cannot be separated from the pervasive culture that accepts and supports frequent and often reckless use of alcohol. This slide shows the different subgroups that need to be taken into consideration when preventing these behaviours. In order to successfully intervene, we must ensure policy choices do not make inequities worse, focus on addressing health consequences for most disadvantaged, reduce the gap between the most advantaged and most disadvantaged, and seek to flatten the gradient across the whole population. The predominant approach to dealing with alcohol use in pregnancy is the development of interventions that encourage people struggling with the issue to change their lifestyle behaviour. These are known as social interventions. Government-led campaigns and educational programs are the main avenue of these efforts. To date, the distribution of alcohol use and alcohol-related problems from an equities and social determinants perspective has largely been neglected. In order to address the issue at hand, we as a society must actively work to destigmatise these behaviours. Psychological interventions have shown success in helping pregnant women with their alcohol habits or helping them to abstain from consuming alcohol. They focus mostly on the affected or tertiary subgroup in this issue. The accessibility of these programs creates a barrier for their success and the effectiveness. Women from lower socioeconomic backgrounds may experience financial strain, less social support, and stigma while trying to seek out these types of therapy. We will take a look at 4 types of psychological intervention. Cognitive behavioural therapy focuses on diminishing the patient's negative automatic thoughts and dysfunctional underlying beliefs that evoke unwanted symptoms through collaborative hypothesis testing, behavioural tasks, and skills training. Brief psychodynamic psychotherapy uses therapeutic relationship to explore and resolve unconscious conflict as well as developing insight and circumscribed change. Interpersonal psychotherapy uses the connection between mood and current interpersonal experiences to focus on 4 problem areas: grief, role dispute, role transition, and interpersonal deficit. Supportive counselling or therapy is non-manualised and experimental, and core conditions of empathy, acceptance, and genuineness are utilised by the therapist within the therapeutic relationship to facilitate the client towards self-awareness and self-determination. Educational interventions may help women to reduce their alcohol intake during pregnancy. These types of interventions have shown the most success in raising awareness at a primary level. These types of intervention include brief educational counselling sessions, structured long-term educational programs, individual-focused educational strategies, family-focused programs, professional group education interventions, self-help group educational interviews, and government campaigns. There is a major lack of knowledge on the topic of alcohol use in pregnancy. In December 2020, the National Health and Medical Research Council released the revised Australian guidelines to reduce health risks from drinking alcohol. They now advise that pregnant women should not drink alcohol. The societal understanding of what alcohol consumption is okay for pregnant women still remains blurred as generational differences in opinion exist. These views often withstand government suggestions as there is no enforceable policies on consuming small amounts of alcohol while pregnant. Campaigns like the DrinkWise Fetal Alcohol Syndrome Disorder Awareness Program utilize broad-based and targeted awareness measures to reach pregnant women, those planning a pregnancy, and their support networks. The campaign reaches consumers through pregnancy sites, magazine, medical facilities, and campaign videos. The program is funded by the federal government via the Department of Health, as well as DrinkWise's contributors and companies such as Coca-Cola, Coopers, Lion, and Australian Grape and Wine. These types of campaigns have shown success as they can incorporate dramatic film techniques in their advertisements to further awareness raised and also reach more of the population in focus. Pharmacological interventions focus on extreme cases of alcoholism during pregnancy. These interventions focus on the affected population. 4 main pharmacological interventions are implemented by medical professionals, including disulfiram, which is a drug that prevents the liver from fully metabolizing alcohol, leading to extremely unpleasant symptoms including nausea, flushing, headache, and high blood pressure. Naloxone is an opioid antagonist and reverses the effects of narcotics and lessens the pleasurable effects of alcohol. And camprosate is a calcium channel blocker that stimulates inhibitory GABA receptors and lessens the pleasurable and reinforcing effects of alcohol. The effectiveness of these pharmacological interventions is quite high. However, their safety in pregnancy has not been demonstrated yet. Thank you for listening.